Ladies and gentlemen, welcome back. We will now begin Symposium 5 in Hall A. This is dedicated to rheumatology with important discussions on hip fractures, osteoarthritis, rheumatoid arthritis, current and emerging therapies. I'm delighted to invite the chairpersons, Dr. Sujeevani Kurukulasuriya, President of the College of Specialists in Rheumatology and Rehabilitation, Sri Lanka, and Dr. Monika De Silva. May I now invite our chairpersons to introduce the speakers and panelists for the session.
Yes, thank you very much for that. So may I first call on stage Professor Ian Cameron, a consultant physician in rehabilitation medicine and the chair in Rehabilitation Medicine, School of Health Sciences, Faculty of Medicine and Health, University of Sydney. He's a clinical researcher. So over to you, Professor Cameron.
So thank you very much for that introduction, and thank you very much to the Ceylon College of Physicians for inviting me to give this talk today. This talk is about ways in which improved outcomes can be achieved for people with hip fractures, and the methods used will be the application of clinical guidelines and use of a registry to monitor how hip fracture care is provided. So there are hip fracture clinical practice guidelines in many countries, but most frequently used is the NICE guidelines from the United Kingdom. And in Australia, we've largely adopted the NICE guidelines, but with some modifications. My work in this area started in about 1990, in fact, when I did my PhD in a topic which was entitled Accelerated Rehabilitation After Hip Fracture. And so many of the issues that became very familiar to me are now embodied in guidelines. And the other personal factor is that both my mother and my mother-in-law broke their hip in the last 5 years. And I was pleased to see that their treatment largely followed the guidelines, but they both had complicated factors that delayed their recovery. The Australian New Zealand Hip Fracture Registry has been in operation about a decade, and then as a result of the registry framework, there's been improved adherence with the clinical guidelines, clinical variations been reduced, and hospitals have demonstrated increasing adherence with guideline recommendation. And I'll show you a few examples of how this has been associated with improved clinical outcomes. I don't have any commercial disclosures. So if we think about what clinical guidelines are available, as I said, the best known hip fracture clinical practice guideline that's evidence-based has been published by the National Institute for Health and Care Excellence in the United Kingdom. The first version was in 2011, and that's been updated on multiple occasions, the last in January 2023. The NICE guidelines have got 9 main components, and I've listed them. Some are quite brief, such as imaging and timing of surgery, but others, particularly multidisciplinary management, have quite a few subcomponents to that part of the guidelines. There are other things I wanted to mention. These guidelines do acknowledge that a hip fracture is an end-of-life issue for some people, and suggests a different management pathway for those. They realise that delirium is a common complication of hip fracture. They encourage early supported discharge, meaning people are mobilised quickly and then get to their usual place of residence. It suggests that inpatient rehabilitation, which is generally called intermediate care in the United Kingdom, needs to be coordinated with a wider hip fracture program. And then it also makes the important point that people who are admitted from care homes or nursing homes, as they're called in some countries, shouldn't be excluded from rehabilitation programs. So the Australian and New Zealand guideline for hip fracture care has now been around for quite a long time, 10 years or so. It's based on the NICE guidelines, and there was just limited modification for Australia and New Zealand use. There were some changes in terminology and some minor tweaking of a few of the guidelines. And there's this, which is too much to read, but it's the plain language summary of the Australian and New Zealand guidelines. So one of the emphases has been that patients and their carers should be strongly involved in the use of these guidelines and their implementation, and so that these plain language recommendations embody that. So I just want to touch on selected indicators from the guidelines that are of physician interest rather than surgeons' interests. And so that this is the current draft annual report for the Australian and New Zealand Hip Fracture Registry. It's been running for 10 years, and it's got a nice infographic about how things have changed over the last 10 years. So I'll just take you through that. So this is a rather complicated diagram, but I'll just see whether the cursor... No, it doesn't. Okay, so the first, it tracks what's happened with a number of the guideline items over the 10 years. Thank you. So I can show you now. So we start from the top here, and we look at the indicator preoperative assessment of cognition, and you can see there's been a major improvement in 10 years. Another item is analgesics. Within 90 minutes of arrival in the emergency department, there's been a moderate improvement there. There's an emphasis on analgesia locally, so a nerve block, and you can see there's a huge improvement over the time there. Initially, surgery was within 48 hours. It's now 36 hours the standard. So that's why we've got just the one value there. Assessment of frailty, as we've discussed earlier in this conference, frailty is a recognised issue, and now frailty is assessed almost universally. It's a new indicator about nutritional status after hip fracture, and that now is tracking along at quite a high prevalence of protein and energy oral supplementation. Next indicator to look at is achieved first day walking. That's increased a little, and from my point of view, that's a particular area where there is more to be done. I'll say more about that. There's an item about delirium assessment following surgery, which is now done fairly routinely. There's an indicator around use of treatment for osteoporosis and initiating that during the initial hospitalisation. There's still a long way to go with that, and I'll comment on that. And then the other one is in this series is the provision of information, which has increased but has a way to go. So in those selected indicators, they're all improvements or new indicators, and there's nothing there that indicates a decline in performance. So just to introduce you to some of the charts in the hip fracture registry report. This is called a caterpillar chart, and it allows a comparison between hospitals. So there's about 100 hospitals submitting hip fracture data in Australia now, and you can see that the average rate of frailty assessment is not 91%. That's almost always using the clinical frailty scale. So that's surprisingly high, but you can still see there's significant variability between hospitals. So each of these abbreviations indicates a specific hospital. So it's very obvious to the hospital and everyone else which hospitals are going well and which aren't. And so that has been a factor in driving better adherence to the guidelines. So looking at surgery within 36 hours, as I said, it was 48 hours, a big spread, but a moderate compliance with that indicator. So this, I'm quite interested in this because I'm interested in recovery, and recovery with reference to mobility is the most important factor for older people. And so first day walking's only being achieved still in about half of people after surgery for their hip fracture. So that's substantially lower than I'd like, and you can see there's a lot of variability. Delirium assessment, done quite well after surgery. Oral nutritional supplements, as I said, this is a new indicator, surprisingly high, but again, a lot of variability. And then bone protection medications on discharge. So it's not very high at all. Some places can achieve it very well, but overall, there's quite a long way to go. So you can see the report from the Hip Fracture Registry provides a lot of data. It provides a comparison, and units who help people with hip fracture can compare themselves with other units and also look at their performance over time. So they can see whether their performance is improving or not as years go by. There is a 120-day follow-up as part of the registry, and there's a health-related quality of life indicator. The EQ5D5L is recommended. What you won't be able to see is the N, and so the number of follow-ups achieved is still relatively low. Data incomplete. And when you look at this in more detail, the data that's being captured is not representative of all people after hip fracture. So the data is likely to capture people who are recovering well because, to me, quite surprisingly, 120 days after hip fracture, a third of people are reporting no problems with mobility. That's, well, it's clearly not indicative of all people with hip fracture. So I wanted to now talk about a few ways that the registry data has been used to improve outcomes or to demonstrate how much outcomes have improved. So there's this study which looked at adherence to clinical care standards and mortality after hip fracture surgery New South Wales, that's the most populous state in Australia with about 8 million people. And it was a retrospective population-based study. And so it involved a comparison where there was a high adherence to clinical indicators compared to a low adherence to clinical indicators. And the conclusion was that quality hip fracture care is associated with improved survival. However, as care for 1/3 of fractures did not achieve high level adherence to quality of care, the delivery of hip fracture care should be improved. So the difference in mortality for high adherence compared to low adherence was about 16%. So it was substantial, 20% and 36%. And the indicators that are captured in the registry the provision of an orthogeriatric model of care, time of surgery, at that stage it was less than 48 hours, mobilise on the day after surgery, have unrestricted weight bearing immediately after surgery, no pressure indication in hospital, pressure ulceration in hospital, and receive bone protection medication prior to discharge. So high adherence, so 5 or 6 of those produced, compared to low adherence, 3 or less, produced a major difference in mortality. The next study aimed to understand why there was that low prevalence of use of bone protective medication. Generally, it's known that there's a huge gap in research findings in terms of bone protection medication and what actually occurs. So this aimed to look at people who had hip fracture who were on bone protection medication before the hip fracture, and then also what happened in hospital and what number of people started that medication. So this is what's called a sprint audit within the registry. So it uses the centres that are participating in the registry. They can volunteer to collect extra information, meaning a sprint audit for a limited amount of time. And so this was what was done. And in this case specifically, reasons for low bone protection medication use were investigated. So that the high-level results are about 10% of people who break their hip are taking bone protection medication in Australia on admission. On discharge, it increases to 22% in Australia and 28% in New Zealand, so modest increases. And then in terms of the reasons for non-prescription during hospitalisation are low vitamin D, so people's vitamin D couldn't be increased quickly enough to be able to give the medications. Renal impairment was the major factor in New Zealand, and then there were a whole range of other issues. Some of those related to availability of medications and cost of medications. So this is, at least in where I work, has helped us focus on our local practice, and we've specifically making an effort to increase bone protection medication use before discharge. In Australia, most medications for osteoporosis are available with a significant government subsidy, but if they're administered in hospital, the hospital may not be able to achieve the government subsidy. So that was one of the reasons why there was a delayed prescription for some people. We're trying to do something about that. Also, generic anti-resorptive medications are more available now. And so this one is about looking at mobilisation strategies after hip fracture and try to quantify the extent to which early mobilisation is of help. So this again is a sprint audit. And then this is a prospective cohort study with statistical adjustments for confounding factors, of which there are many. And one of the criticisms of this study is that there's probably residual confounding. And so the benefits are probably overstated a bit. And so, again, headline results, if you're mobilised on the first day after your hip fracture, on average you reduce the length of hospital stay in Australia by about 2.5 days, which is a significant amount. And if you're mobilised on day one, you also have a significantly greater chance of being discharged directly to home rather than to a rehabilitation ward or a nursing home. And so this gave further stimulus to offering early mobilisation. When you look at the issues practically, you do need to have staff available to mobilise over the weekend. You need to cover leave time, you need to cover sick leave. So there's, when you look at it in more detail, even though there's a clear benefit, it's still quite hard to achieve mobilisation on day one after the hip fracture surgery. Just to reflect, I'm getting close to finishing, what's still to be done. It would be nice to see guidelines used in more countries, in my opinion. It's been a powerful tool in the United Kingdom and Australia and New Zealand, but there is a cost involved in that. So there's an upfront investment, and then there's either goodwill or ongoing financial contributions from participating hospitals. We definitely need more complete data at 120 days after fracture because we're not routinely monitoring longer term outcomes for people with hip fracture, and that's what is most important. We do need to get that health related quality of life data because with that health economic analyses can be done with a more effective comparison between different techniques. We also need to develop and refine hip fracture rehabilitation indicators, and the first day mobilisation is a good start. We need a hospital indicator about frequency of mobilisation, and then we need post-hospital indicators of treatment frequency, which would probably be strength and balance training. The other just comment to note is that the indicators are usually agnostic for the type of health professional that delivers the treatment, and so it's trying to encourage a team-based approach where the role of different disciplines is somewhat fluid. So to finish, the hip fracture clinical practice guidelines based on the UK have been adopted, in Australia at least. They have been quite effective. Outcomes have been improved and clinical variation has been reduced. Thank you.
Thank you, Professor Cameron, for informative talk on a very interesting topic. Yeah. So at the end, so we'll take you can take up questions at the end of the lecture. And now may I invite Dr. Chamila Dabare to talk on osteoarthritis and update beyond pain. Dr. Chamila Dabare is a rheumatologist at Western Health, Melbourne, Victoria, Australia. She's an honorary lecturer at University of Melbourne. Over to you, Dr. Chamila.
Thank you so much for that kind introduction. And thank you, Ceylon College of Physicians, for inviting me for this talk. So my topic today is osteoarthritis and update beyond pain. First of all, I have no relevant disclosures or conflicts of interest. Osteoarthritis is the most common musculoskeletal disorder, particularly affecting weight-bearing joints like the knee, hip, and spine. It's one of the leading causes of disability worldwide, increasing prevalence due to the aging population and the rising rates of obesity. It's a chronic condition leading to significant economic burden with costs related to medical treatments, joint replacement surgeries, and lost productivity. And OA is the biggest unmet medical need among the many musculoskeletal conditions. So what is OA? Is it just wear and tear arthritis that we have to tell our patients to live with? No, it's not. OA is a complex inflammatory and metabolic syndrome involving the entire joint tissue, affecting the articular cartilage, synovium, bone, and soft tissues. OA is characterized by degradation of articular cartilage, synovial inflammation due to pro-inflammatory cytokines, such as cytokines and chemokines, subchondral bone remodeling, and formation of osteophytes. A little bit about OA pathogenesis, so we can think about the treatment targets, potential treatment targets. So cartilage is avascular, and it depends on mechanical forces to stimulate cellular activity and facilitate nutrient exchange through compression and shear forces. And the chondrocytes are the sole cellular component of articular cartilage, which respond to mechanical loading by modulating gene expression. And the mechanical loading regulates chondrocyte metabolism by upregulating the expression of anabolic genes to produce structural components of the cartilage, such as type 2 collagen and aggregates. And OA results from an imbalance between catabolic and anabolic factors in the joint with upregulation of catabolic enzymes promoting cartilage degradation, such as matrix metalloproteinases or MMPs and ADAMTs, it's a long name, and pro-inflammatory cytokines such as IL-1 beta, IL-6, and TNF-alpha. And it's a multifactorial disease influenced by biological factors such as obesity, aging, gender-related differences, genetics such as mutations in collagen, and anatomic factors such as femoroacetabular impingement of the hip and valgus and varus deformity of the knee. And there are biomechanical factors such as mechanical loading and joint injury contributing as well. So this shows the normal joint structure on your left-hand side, showing normal cartilage in dark green color here, and then normal synovial membrane here, and the normal subchondral bone. On the other side is the pathology in OA joint, where you can see eroded cartilage with synovial hyperplasia due to synovial inflammation and subchondral remodeling with formation of osteophytes. This is another depiction of the cross-sectional view of the same. As you can see, the nice and clear cartilage on the normal joint is eroded in this one with OA. And the subchondral bone disturbance is seen here. So let's talk about a little bit about different pathogenic factors in detail. With obesity, adipose tissue has macrophages which can produce pro-inflammatory cytokines, leading to an inflammatory environment which contribute to cartilage degradation, such as the TNF-alpha, interleukin-1 beta, and interleukin-6. And the adipocytes produce adipokines, which are signaling molecules such as leptin, adiponectin, and resistin. Leptin increases matrix degradation enzymes such as MMPs. And also, obesity causes mechanical overload on the joints, leading to microtrauma in the articular cartilage, triggering a cascade of inflammatory responses. What about aging? There are several mechanisms which contribute to osteoarthritis. Aging of the extracellular matrix leads to thinning, dehydration of cartilage, accumulation of advanced glycation end product proteins called AGEs, and abnormal calcification such as calcium pyrophosphate. Also, aged cartilage cells called senescent chondrocytes contribute to inflammation and cartilage breakdown. Sarcopenia is another hot topic these days, which is decline in muscle mass and strength with aging. Loss of the muscle mass results in weak muscles, leading to altered gait patterns with abnormal joint loading, especially in knee and hip joint. As well as loss of muscle strength significantly impacts joint stability, increasing the mechanical load on the articular cartilage. What about gender difference? Hormonal, anatomical, and biomechanical differences in men and women are the key factors here. Women are more prone to developing osteoarthritis at an earlier age than men due to hormonal variations as well as anatomical variations. Hormonal variation is mainly depending on the estrogen. Estrogen helps cell proliferation and viability, which decrease the cartilage damage in OA. Reduction in estrogen levels with menopause accelerates cartilage degradation, particularly in the knee and hip joint, leading to OA. Gender-specific anatomical differences in women is another cause. Women having a wider pelvis results in a greater Q angle, the angle formed by the quadriceps muscle and patellar tendon, compared to the men. This increased Q angle contributes to higher stress on the medial compartment of the knee, a common site of OA development in women. As well as that, lower muscle mass and strength in women, especially in the lower extremities compared to men, with less sufficient load distribution across the joints lead to abnormal joint loading and increased risk of OA. What about biomechanics? It can be a double-edged sword. It can be useful as well as harmful. As we discussed earlier, normal mechanical loading activates useful mechanosensitive pathways in chondrocytes, such as mitogen-activated protein kinase, integrins, WNT beta-catenin signaling pathways. With excessive or inappropriate mechanical loading, this can lead to upregulation of catabolic enzymes promoting cartilage degradation, such as MMPs, ADAMTs, and pro-inflammatory cytokines. So how do we treat OA nowadays? So we use non-pharmacological therapy, which is a very, very important component of OA management, physiotherapy, weight management, and patient education. And pharmacotherapy is not ideal, but the options we have are pain management with simple paracetamol, oral or topical anti-inflammatories, opioids, and sometimes duloxetine. We use intra-articular injections in certain situations. And then we consider surgical management for advanced disease with osteotomy and arthroplasty. So this shows 2019 ACR guidelines for management of osteoarthritis. On your left-hand side is the non-pharmacological measures, and the recommendations in dark green are the strongly recommended ones, the light green are the conditional recommendations. In non-pharmacological therapy across the board, exercise and self-efficacy, self-management, and weight loss are strongly recommended. Under pharmacological therapy, oral anti-inflammatories are recommended for all osteoarthritis joints, with topical NSAIDs used for hands and knees. Intra-articular steroid injections can be given to any joint with OA in certain situations. And the others are conditional recommendations, including paracetamol, tramadol, duloxetine, and various other topical measures, such as topical capsaicin. So far, there are no recommendations from trials to use supplements, such as glucosamine or chondroitin. So let's talk about intra-articular injections. It's a localized and minimally invasive technique. There are traditional intra-articular therapies primarily aiming to reduce the pain, but they lack regenerative capacity, such as steroids and hyaluronic acid. Biological intra-articular therapies are autologous blood-derived products, such as PRP, bone marrow aspirate concentrates, and mesenchymal stromal cells. There are investigational therapies, such as fibroblast growth factor 18 and gene therapy. A little bit about intra-articular steroid injections. This is used for symptomatic management when non-pharmacological treatments or the first-line pharmacological agents are not successful. They have short-term efficacy, can last from few weeks to few months, up to 3 months sometimes. A meta-analysis of intra-articular glucocorticoids in persons with knee and hip osteoarthritis showed the magnitude of effect was more pronounced when there's high baseline pain, and treatment response is seen from moderate pain levels and beyond. There was no concrete conclusion made on inflammatory signs in osteoarthritis. Hyaluronic acid is most commonly given to knee joint, but it can be used for other joints, such as hip, shoulder, and ankle. The cost of hyaluronic acid in Australia can be $300 to $600 for the product itself, and additional cost for the consultation and the injection procedure, whether it's done at a doctor's consultation or at a radiology place. There are mixed results from trials regarding the efficacy and safety so far. And there's only a small clinically insignificant benefit over placebo in trials. So a meta-analysis of best evidence knee OA trials with 24 double-blinded sham-controlled trials with at least 60 patients showed no clinically important differences of hyaluronic acid treatment over placebo. Then another meta-analysis of 24 large placebo-controlled trials on knee OA, more than 8,000 randomized participants. There was a modest reduction in pain intensity and functional outcomes compared to placebo. So you can use your judgment when you are treating a patient to use this or not to use this, depending on risk-benefit ratio. What about PRP? This is an autologous blood-derived product with a cocktail of various bioactive concentrations of growth factors. Potential for modifying disease progression by regeneration of degenerative tissues is the idea here. And efficacy and safety still remains controversial in well-designed trials. And the cost of PRP injection can range from $300 to $1,000 in Australia, cost depending on several factors, including the specific clinic, the type of PRP used, the number of injections needed, and whether ultrasound guidance is used. So a meta-analysis of 40 trials, including over 3,000 patients with knee OA, comparing PRP with hyaluronic acid, corticosteroids, and saline, showed PRP was not superior in improving pain or function compared with all the other products. Then again, another meta-analysis of over 5,000 articles, 18 randomized controlled trials, including nearly 2,000 patients with knee OA, showed PRP offered clinically relevant functional improvement at 1, 3, 6, and 12 months follow-up points, and pain relief at 3 and 6 months follow-up points compared with placebo. But the platelet concentration was found to influence the treatment efficacy, with high platelet PRP providing superior pain relief and more durable functional improvement compared with low platelet PRP. So what about DMARDs in osteoarthritis? As you know, treating rheumatoid arthritis is very easy these days. We have all the conventional as well as biological DMARDs, and our aim is treat to target therapy to achieve disease remission as soon as possible. This is the billion-dollar question in OA space. So far, there are no proven or approved disease-modifying osteoarthritis drugs called DMARDs. But there are trials in pipeline, so at least there is some hope, some light at the end of the tunnel. So this shows the array of options we have for treating rheumatoid arthritis over the years, and there are more coming. I'm sure we're going to talk about it in the next lecture. With potential treatment targets for OA, depending on the pathogenesis we discussed, I'm going to talk a little bit about these options, the potential targets: targeting inflammation, reducing cartilage breakdown, promoting cartilage repair, targeting bone remodeling, and targeting pain. So I'm going to talk about a few trials these scores are used. So I'm just giving the baseline idea about these measures. Visual analog scale is a pain measure we use in trials. It's a continuous line for a patient to mark their pain level, can be from 0 to 10 or 0 to 100. 100 or 10 being the worst pain. Numeric rating scale is a simpler verbal or written version of this. a number to represent pain intensity and segment a scale so the patient can choose a number. So Western Ontario and McMaster University's Osteoarthritis Index or WOMAC score is used to assess pain, stiffness, and physical function in patients with hip and knee OA. It consists of 24 items rated on a 5-point Likert scale. So let's talk about targeting inflammation options. So steroids, conventional DMARDs, biological DMARDs such as TNF-alpha and IL-1 has been trialed, and other inflammation pathways like GM-CSF, granulocyte macrophage, colony-stimulating factor has been trialed. So targeting inflammation with steroids. So this is a small trial, HOPE trial, with 92 patients with hand OA and positive synovitis in ultrasound. 10 milligram pred versus placebo for 6 weeks with 2 weeks taper, then 6 weeks follow-up. The primary endpoint was met, which is the VAS, the pain score, at 6 weeks, but pain returned once the drug was stopped. So the long-term clinical efficacy is questionable. What about conventional DMARDs? So methotrexate has been tried a few times. There are small trials like this. So 97 patients with hand OA with synovitis with methotrexate 20 milligram. Primary outcome was favorable with a VAS pain reduction at 6 months at a significant level. And then another study with knee OA, Kagan-Lawrence 3 to 4, advanced knee OA cases. And primary outcome, again, average knee pain improvement was favorable. Then there was this systematic review which was published very recently in osteoarthritis and cartilage, 6 randomized controlled trials involving 602 patients. Methotrexate was significantly able to relieve pain compared to the placebo in knee and hand OA. Functional improvement in knee OA was weak though, but there was no difference in quality of life outcome and no increase in incidence adverse events. So there is an ongoing Norwegian study called Merino study, which is ongoing at the moment. It's a randomized placebo-controlled trial in people with erosive hand osteoarthritis with methotrexate 20 milligram weekly. Aim is to assess efficacy as well as safety with data on symptoms, synovitis by imaging and clinical examination, and radiographic progression. Let's watch out the space for this trial outcomes. Coming on to biological DMARDs, TNF inhibitors, which we are very familiar in using in rheumatoid arthritis. So etanercept has been used in a randomized controlled trial in 90 patients with erosive hand OA. Unfortunately, primary outcome VAS score was not met so far. And then adalimumab has been trialed on 43 hand OA patients with X-ray erosions and MRI synovitis. Again, primary outcome with the pain score was not met. And there was no effect on MRI synovitis or bone marrow lesions. GM-CSF is a mediator of inflammation and pain in osteoarthritis. We are actually currently doing a study on this with our unit and the AIMS, Australian Institute of Musculoskeletal Sciences, to get more information on this. This is a phase 2A randomized controlled trial on 44 patients with inflammatory hand OA with MRI synovitis, subcut otilimumab versus placebo for 10 weeks. Unfortunately, primary endpoint was not met, but there was trend towards reduction in pain and function impairment. So it needs more trials to get more information. Next target is reducing the cartilage breakdown. Protease inhibitors, so main target is blocking proteases, which are catabolic enzymes promoting cartilage degradation. Like we discussed earlier, ADAMTs and MMPs are the main targets. There was an investigational product for ADAMTs, phase 2 double-blind RCT, unfortunately did not meet primary endpoint, which is MRI medial compartment cartilage loss, or secondary endpoint, which is WOMAC and VAS scores. Next target is promoting cartilage repair. So fibroblast growth factor is still in trial. So this is a recombinant human FGF18 sprifermin. A dose-finding study was done. It showed increased cartilage thickening and reduced cartilage loss at 24 months with 100 microgram of sprifermin every 6 to 12 months but pain efficacy was not assessed in this trial. So this is kind of gene therapy in osteoarthritis, still in trial stage, transforming growth factor beta. It has anti-inflammatory effects, promoting chondrocyte proliferation. So intra-articular tissue gene C is an allergenic chondrocyte transduced to overexpress TGF-beta. It's a phase 3 randomized controlled trial with 163 knee OA patients, and primary endpoint was met at 52 weeks. That's positive results. So the FDA has done phase 3 trial, completed dosing in July 2024. We are waiting for the results of this trial. Next target is targeting bone remodeling. Bisphosphonate has been trialed in this on 190 patients with knee OA, subchondral bone marrow lesions on MRI, yearly solidonic acid versus placebo. Primary endpoint was not met, unfortunately, which is total change in tibiofemoral cartilage volume at 24 months. Another target is nerve growth factor, targeting pain. NGF is a pain mediator with increased expression on inflamed or injured tissues. And a drug, tanezumab, is an NGF inhibitor, has been trialed in a proof of concept study on 450 patients with moderate to severe knee OA. Primary endpoints were met, which were knee pain reduction and patient global assessment improvement, but this was partially withheld due to the concerns of osteonecrosis. And then there was a follow-up study, phase 3 double-blind placebo RCT, with nearly 3,000 patients with hip and knee OA, with 56 weeks treatment. Again, one of the primary endpoint was met, which is the change in WOMAC pain and function at week 16, but the patient global assessment for pain was not met, or the function was not met at week 16, and actually found it's not osteonecrosis, it's rapidly progressive osteoarthritis, the cause for the pain. And there were increased rates of joint replacement in the study group, so the study had to stop due to safety concerns. Another target is targeting pain. We can try nerve blocks and radiofrequency ablation, targeting genicular or saphenous nerves. This is a small study, 12 weeks double-blind placebo RCT with genicular nerve block on 59 patients with knee OA, with 3 injections versus saline, and the VAS pain reduction at 2, 4, 8 were met. 12 weeks was not that great, but there were no complications. We actually do this in Australia for our very severe patients as a rescue measure before we refer to the surgeons. So how can we deliver integrated, comprehensive care in osteoarthritis with all this base background knowledge? So this is an initiative we have in Australia, OAKS clinics, or Osteoarthritis Hip and Knee Service, which is a model where there's a multidisciplinary OA team, a dedicated OA clinic, led by rheumatologist with nurse, physiotherapist, dietitian, and other allied health services. Our OAKS clinic is based at St. Vincent's Hospital, Melbourne. This is the service model. So we get referrals from various sources, primary care physicians, specialty physicians, internal referrals from the hospitals, and external referrals. So they are triaged, and we see them in our clinic, and we work with the allied health teams. And if they improve, we continue care, or we refer back to the original referrers for ongoing care. If they get worse, we refer to the orthopedic clinic for consideration of surgical management. So this is an outcome study of our OAKS clinic. It's a 6-year follow-up study of 247 consecutive patients who attended OAKS clinic. Primary endpoint was joint replacement surgery. 77% of the knee OA patients and 58% of the hip OA patients improved with conservative treatment, not needing arthroplasty. And it suggests that structured conservative management works well for both groups. This is an ongoing study with long-term data. We are in the process of our next publication. So this is the blue line is the knee osteoarthritis patients who have stabilized over time, and the hip OA patients, although at a lower level, still stabilized. In summary, osteoarthritis is a whole joint disease it's just not wear and tear. It's a whole joint disease with inflammation as well. And management of OA is challenging. Main goals are function, symptoms improvement, and delay in progression. And not everyone needs surgery. And some promising therapeutic targets are in the pipeline, as we discussed so far, but the limitations being they are small studies, often short duration, and the statistical versus clinical significance is a question, as well as optimal outcome measures we are yet to find. And the challenge is, OA is a heterogeneous disease with varied risk factors, different phenotypes, different joint involvement. My acknowledgements, and thank you.
Thank you, Dr. Dabare, for that very interesting and comprehensive lecture. We'll take up questions at the panel discussion. Thank you. My next pleasant task is to introduce Professor Inoshi Atukorale, Professor in Rheumatology at the Department of Clinical Medicine, Faculty of Medicine, Colombo. She's an honorary consultant rheumatologist at the University Medical Unit, National Hospital of Sri Lanka. She will speak us to on rheumatoid arthritis, what a physician should know. Over to you, Inoshi.
Good afternoon. As healthcare practitioners, many of us struggle to provide optimum care for rheumatoid arthritis patients, but there are many new therapies for this once disabling disease and many strategies where we can treat these patients better. So I thank the CCP for recognizing this fact and inviting me to talk on current and emerging therapies in rheumatoid arthritis, what every physician should know. I have no financial disclosures, so I'll talk about why this topic is important. What do the current guidelines recommend? Is there anything else we can do for our patients? And then focus on what's coming up next. So why is this topic important? Rheumatoid arthritis is a chronic, deforming, disabling arthritis. It is life-changing, causing progressive disability, premature death, and high socioeconomic consequences. Its impact to the patient is immeasurable. The prevalence in Sri Lanka is not known, though from our study we got an early arthritis prevalence of 0.7%. I think of rheumatoid arthritis like a war. It is aggressive synovial inflammation with cytokines and systemic factors which wreak havoc on the body and on the joint, causing pain, functional disability, ultimately causing utter damage to the joint as well as to the rest of the body. We are fortunate that there are many new targets, but even more importantly, we have new understanding of the disease about window of opportunity, treating to target, as well as discovering early rheumatoid arthritis. It's good that we have a lot of weapons to fight our war. We have some conventional disease-modifying agents. We have steroids. We have biological disease-modifying agents. And we have targeted synthetic disease-modifying agents. So what do the current guidelines recommend? I'm making this a lot more focused on what is practical for people in the audience. So the first thing is always to start with methotrexate and to combine it with steroids, low dose as possible, and to stop it and taper it off as soon as possible. If that is not possible, we have two other agents. So this is like an all-out war. Everywhere is being attacked. And the main thing is methotrexate. And though it is technically a dihydrofolate reductase inhibitor, in rheumatoid arthritis it works with the AICA transformylase inhibition, which inhibits neutrophil adhesion and cytokine release and T-cell activation. It's the main drug, it's first line, it's used singly or in combination with other drugs, and we use it in all guidelines unless it is contraindicated. We should start it early, step up the dose as soon as possible, and it works best with combinations. And patient education is critical in this drug use because there are some side effects. And the commonest one is actually gastrointestinal side effects. Maybe about 10% of our patients do have this. And to circumvent this, we can potentially split the dose. And there are multiple regimens where we can split it over 1 day, maybe 2 days. We can start low and titrate slowly so that the patient doesn't get fed up with it. And we can also take it after food to lessen the GI disturbances. In other countries, they switch to subcutaneous methotrexate fairly early if there's intolerance, but that we do not have freely in our country. So we tend to use the strategies which I mentioned above. Using folic acid can also reduce the GI side effects, and it is very important for hematological side effects. Liver side effects are the commonest one we encounter because we have a large proportion of MASLD or metabolic associated liver disease in our community. So screen your patients for risk factors, ask them to avoid alcohol, manage their weight, control their diabetes and dyslipidemia, and also be vigilant of hepatotoxic drugs. Again, the lowest dose which we can use in combination with folic acid. We need to monitor the liver functions regularly, and once the patient is stable, we can switch to 3 monthly. But watch out in our patients because we do get mild elevations of liver function tests, and those we can manage with dose readjustment. But if it is more than 2 to 3 times the upper limit, we should stop. And then our gastroenterology colleagues will step in and assess whether we need to stop the drug and assess fibroscans and elastography. Around 20% of patients show elevated transaminases. Mild elevations are common, but severe progressive problems are only in 1% of the population. There is a scare about methotrexate-related pulmonary toxicity, but pulmonary toxicity due to methotrexate occurs in a minority, and it is by definition idiosyncratic and a hypersensitivity interstitial pneumonitis, which has a cough, shortness of breath, and fever, usually within a few months of starting the drug, not end stage. You get infiltrates on imaging, and it is common in older people with lots of lung diseases and particularly other comorbidities. What I want to reiterate is that methotrexate is not a cause of chronic progressive pulmonary fibrosis based on current evidence. And the main driver of interstitial lung disease in rheumatoid arthritis is rheumatoid arthritis. And this is to show you a picture of a patient who has had interstitial lung disease but has been in the minority who have recovered. What about the other conventional disease-modifying agents? Sulfasalazine is better than placebo, but that's it. It works best with triple therapies in combination with methotrexate. The same is for hydroxychloroquine. It has very, very minimal monotherapy efficacy, and again, it has better effect if we combine it with combination therapy. And combination therapies are very useful. And you can look at this combination therapy versus a biologic and methotrexate, and it's not doing too badly. Similarly, when you combine it with lots of other, and ACT is actually conventional therapy, CSAP is acetylizumab, abatacept, and tocilizumab, and you can see that the curves run a pretty much similar place. So even for us, if we use the conventional drugs sensibly, we might be able to manage. Leflunomide came out at a bad time because it came out with the first biologic etanercept. It could not compete with etanercept on its own, but it has some useful effect in our populations, and it does have a similar efficacy to methotrexate. You get diarrheas in about 20% of patients, nausea, alopecia in about 10%, but you can modify drug dosing and minimize that. Liver enzyme elevation is about in 20%, and hematological side effects in about 4%. Severe hepatotoxicity and cytopenias are less than 1%. So what about our old friend or enemy, steroids? Useful in bridging therapy, because the biologics and even conventional disease-modifying drugs particularly take time to work. They are useful for treating flares. Orally, we prefer intra-articular or intramuscular, and there are some studies to show that. We do not want long-term. And glucocorticoids do improve disease activity and functional status, and they can potentially delay radiographic damage, and I'll show you some pictures here. This looks not too bad. Here's steroids in the light blue line compared to placebo, and it shows that it improves DAS scores and it improves disease activity states. It also improves erosions if you use it low dose for about 2 years, as in the Gloria trial. So we have a window of opportunity, and we need to work within a few weeks of diagnosis, ideally within 12 weeks. If you start disease-modifying agents early, you can reduce structural damage, reduce progression, and improve physical functioning. Rheumatoid arthritis occurs in someone who is predisposed. And what happens in these people is that there are genetic initiation, genetic predisposition, and initiation of autoimmunity, and then there is propagation. And that is where the newer therapies can potentially act. You have genetic risk and susceptibility. You have generation of neoepitopes by post-translational modifications, antigen loading, and migration into the secondary lymphoid tissues. You get lymphocyte recruitment, and then begins the inflammatory cascade with cartilage and bone destruction and joint damage. So these potential targets are there for us to treat, to target. You can block anti-CD20, block the TNF molecule, block interleukin-6 receptors, block the T-cell interactions, or the new kids on the block, block JAK-STAT signaling. So we have targeted therapies. And then the guidelines do recommend to add a biologic DMARD if the disease is not controlled within 3 to 6 months. This is a 2023 guideline, and the newer guidelines which are coming out are going to delete this bit about the poor prognostic factors and focus mainly on the biological DMARD use, irrespective of the poor prognostic factors. So what are the biological DMARDs? We have a whole array of anti-TNF drugs. They improve disease activity. They have sustained improvements and safety. They reduce radiological deterioration. And the main issue is that they provide fairly rapid symptom relief, functional gains, and radiological damage inhibition. They are useful in methotrexate inadequate response, methotrexate naive, and even patients who have TNF experience when you switch. The anti-TNF receptors which we have target both the TNF1 receptor and the TNF2 receptor. One is the one which we need to block, that is the inflammatory one, and the 2 is the one which has some anti-inflammatory and tissue protective activities. So the tendency is to move to these drugs as time goes on. B-cell depletion is very popular, and this is the common mode that we use in our country due to the flexibility of the dosing, that we have only to contend with 4 doses, and we don't have to wait for the government to supply biologics on a monthly basis. But there is the problem of hypogammaglobulinemia, infusion reactions, and this is all in the hospital. So that is troublesome for the patient. Interleukin-6 inhibitors are also available, tocilizumab and sarilumab, and they are very potent drugs, some which you can use subcutaneously. And the interleukin-1 blockade and the interleukin-17 blockade really didn't work. So they are not being used. Abatacept, which works with T-cell co-stimulation modulation is useful, and again shows clinical benefits and has a very favorable safety profile, and particularly useful in seropositive patients. Let's come to the new kids on the block, the targeted synthetic DMARDs. So these suppress intracellular signaling, which is mediated by multiple cytokines, and these cytokines are problematic in rheumatoid arthritis. There are 4 genus kinase proteins and some signal transducer activators of transcription, which we call the STAT transcription factors, and they work with a multiple amount of molecules, as you can see. So it seems like they might be very useful. They work downstream in the signaling pathways. And if you look at this diagram, and I'll give you a little time to look at it, in orange are the molecules. You can see that the JAK-STAT pathway might be really useful in rheumatoid arthritis treatment in the future. It works in people who are methotrexate naive, people who are inadequately responding, or even with people who have been what are classically difficult to treat. There is tofacitinib, baricitinib, upadacitinib, and filgotinib, and we have tofacitinib in our country, and I understand we will get upadacitinib soon, still awaiting. But the bigger diagram which I want to show you is this one, and look at baricitinib in red and adalimumab in blue. And it seems that these JAK inhibitors might be better than the conventional drugs we have. But there are concerns. There is an infection risk, and it is very common to have zoster with JAK inhibitors, and there is a dose-dependent infection risk, and the FDA has put out a warning. Despite this, more agents are being developed because these drugs are in long-term studies, in clinical practice, and in registries. The risk of all those worries, it has not been shown. So I think FDA might overrule, and certainly the pharmaceuticals think so. So they are much better, probably, at least in some point, to the anti-TNF. And they are good combined with methotrexate, and it can be used even without. So most of these biologics work if we work them with methotrexate, because methotrexate has a potency to reduce anti-drug antibodies. So we need to extend the use of the conventional disease-modifying drugs, not only in our country, but in other countries, and we need to treat to target. And there are many scores, not enough, I think, which are useful for us to identify whether our patients are getting better or not. And in the interest of time, I will move to this one. If patients do not respond, we keep on changing, and we go running around in that vicious loop. But if they improve, then we can consider dose de-escalation. And sometimes I feel that remission in rheumatoid arthritis is as idealistic as world peace, fairly difficult. But there are many things we can do for patients until they reach this very strict definition of remission. 0 swollen, tender joints are not easy to achieve in most of our patients. Question is, when do we define remission? Can we tail off after 6 months? Can we tail off after 1 year? 6 months possible, particularly if the patient has low inflammation. But a large proportion of patients will have a flare when their disease-modifying drug is tapered. But 90% can control the disease once treatment is resumed. But the focus has to be on multidisciplinary care, because we need to promote adherence. We need to have physio, psychological therapies, specialist nurses. We need pharmacists, dietitians. We need the whole horde of them. We need to also be cognizant that in the difficult to treat patient, there may be other joint diseases like osteoarthritis or a non-articular pathology or even fibromyalgia before we label them as difficult to treat. Patients have a very high infectious risk due to therapy as well as the disease. And if we control the disease and taper the steroids, we have better luck. But please remember to vaccinate your patients because we need to offer vaccination early so that patients can build up a response. This is not always practical. And I know that we may miss out on this step. You need 2 to 4 weeks for immunogenicity to start, and you do not want to start a potent immune suppression in a patient who is on a very strong drug with a live vaccine. COVID vaccination we must try with because those are not live vaccines. Cardiovascular risk is also very high in these patients. It is not only due to the traditional risk factors but also due to inflammation and steroids. So systematically and regularly screen your patients. There you multiply your cardiovascular risk assessment by 1.5. According to the EULA recommendations, because that is our risk of rheumatoid arthritis and cardiovascular disease is about almost comparable to diabetes. So we need to be very careful of our patients because we can't treat their rheumatoid arthritis alone. We need to treat their cardiovascular risk. I won't be talking too much about osteoporosis, but we have to pay attention to that particular fact as well. Most of our patients are young and they might get pregnant. So we need to have this discussion early. So what's coming up next? What's on our radar? There are many drugs which we can consider, but they are still all in the pipeline. We can inhibit GM-CSF and upset the inflammatory cascade. We can change our microbiome and prevent the perpetuation of the immunogenicity. We can we can inhibit the tyrosine kinases. We can expand the T regulatory cells. We can also inhibit TYK2, which is working with the JAK-STAT pathway, which I mentioned. And if not, we can wipe it all out with CAR-T therapy. But for me, the real future is in personalized medicine. At the moment, people are looking at synovial biopsies to figure out who is interleukin-6, who is TNF-alpha. But if we have better ways, maybe with a blood test to identify the patients at risk, then we can choose the targeted therapy to the patient. And then they will have less side effects and better efficacy. So personalized medicine, I think, is the way forward. So, in conclusion, the treatment of rheumatoid arthritis has been revolutionized. We have a better understanding of the disease, and this has translated to improvement, treatment, and outcomes. There is a window of opportunity which we must meet. We must treat to target, and if our conventional drugs do not work in combinations, we must go for targeted disease-modifying therapy. Methotrexate is still the main drug. It is cheap, it is effective, and we are dismissing it too soon. We must use it to its best advantage. Treatment with biologics must be done early if methotrexate fails, particularly in combination therapy in our setting. Management of the patient is multidisciplinary. We must use all the resources we have to improve patient outcome. The rheumatologist or the physician cannot manage alone. We must pay attention to functionality of the patient, the moods, the stress they have with the disease. We must address their infection risk, their cardiovascular risk, and honor their pregnancy wishes. By working together as a multidisciplinary team and by using the effective tools and therapies we have today, we can truly improve the quality of life and the long-term outcomes for our patients with rheumatoid arthritis. I have a few acknowledgements, and thank you for listening.
Thank you, Inoshi, for excellent talk on rheumatoid arthritis. Now I would like to invite all three speakers and also the panelists, Dr. Chathurika Dandeniya, Dr. Chiranthi Liyanage, and Dr. Sonali Gunathilake to be seated on stage.
Thank you very much. Now we have a panel which will last 15 minutes for questions that you might have from the talks that went on. Any questions? Professor Cameron, I wanted to ask you a question. Would the pre-operative bone mineral density affect the prognosis after surgery?
Good question. I think not. I think other risk factors would be much more dominant, particularly whether the person's frail, whether they have dementia, whether they have multi-morbidity. That will have a bigger effect.
Thank you. Thank you for that. Anything you want to add to that?
No, I just wanted to actually ask about the osteoarthritis management. Like all these potential targets are there, particularly with our increasing understanding of the pathophysiology and the pathophysiological mechanisms. What are the therapies that are actually using in practice? What would you recommend?
Very good question. We actually can use methotrexate these days if there are inflammatory signs. I usually use it for large joints if there's monoarthritis even, like actual inflammation, clinically or radiologically. And if the hand osteoarthritis, there are more than 2 joints inflamed in the same hand, we still can use methotrexate as a DMARD. And sometimes, like we can use short course steroids. Yeah, and like weaning off over 3 months or short courses as needed for up to 1 to 2 weeks.
Yeah, I think the important thing is what you stressed upon, if there is actual inflammation, because with a lot of these rheumatological diseases, the patient population is so heterogeneous, like even the risk factors are heterogeneous, and therefore the underlying mechanisms are so heterogeneous. So for the majority of patients with osteoarthritis, in my experience, they can be managed with NSAIDs and the non-pharmacological methods, including weight reduction, physiotherapy and all, but there is a subset that do have actual inflammation that is detectable, and it's important to pick those ones up and try the therapies. And I think we were having a discussion as well that it's about managing the risk and the benefit and the cost in terms of selecting the therapies, I suppose.
It's actually a very timely question, yeah.
Yeah, I also agree, particularly when it comes to PRP injections, because there's been a lot of talk and there is a lot of interest, particularly among the surgical community, I would say, rather than the physicians, about giving PRP injections for knee osteoarthritis. And oftentimes we have patients coming and asking us, is that something that we can try? And so far, I think all the international guidelines that are there in place, they recommend against the use of PRP injections, mainly given the comparable efficacy, if at all, to steroid injections, which are much less costly. And honestly speaking, like a lot of the larger studies that have been done has shown no improvement. And one thing that we are struggling in our healthcare sector is the cost. So I believe, like it's in my practice also and my personal belief, that PRP might not be that suitable an option for care in Sri Lanka.
So there are 2 schools of thought actually here. There are some patients who actually respond because in Australia, there's a very, very high demand for that. I don't have the centrifuge at my practice, so I don't do them, but there are actual GPs doing it. But, you know, the standardization of those techniques, I cannot guarantee. But there are a lot of well set up radiology clinics doing it. And my personal experience is if the patient asks me about PRP injection, I say it's another option instead of steroids. So if the patient is demanding that, I say you can have it and see, because I don't think it's harmful. In medicine, the first principle is do no harm. So if in a well standardized practice, if you can do it with good PRP concentrate, not, you know, it depends on the platelet concentrate, the response. So if you do, I recommend there are certain clinics that do highly standard techniques like the Olympics Park. We have this treating sports people getting PRP injections for tendon injuries and all. So I recommend some places so they don't go to a sham place. Like, so then there are people improving. So I don't recommend as a treatment option, but if the patient volunteers with that, and if they want, I say you can have and try it and see. Yeah.
Okay, according to our experience, so we have after giving PRP two weekly 3 injections. So actually only early osteoarthritis, actually they were pain-free almost about 3 years, but with proper selection of patients. Actually, one of my SRs presented a poster in BSR as well. That one, but I don't know according to our practice, so it's effective, but in selected patients.
Exactly. That's always the case. You need to select the patients, and not only everyone responds.
Okay. How about geniculate artery embolization in osteoarthritis?
Sorry?
Geniculate artery embolization?
Yeah, so genicular nerve block, I refer to radiology because in your clinic you can't do the anatomical demarcation. So there are radiology clinics, they do the genicular nerve block with celestone and various other steroids. Yeah.
Is it genicular artery embolization or block nerve block?
No. Just infiltrating the steroids around the nerve, so to numb the nerve.
Okay, right. Thank you.
Any questions from the floor? Professor Atukorale's lecture was so crystal clear. I think it has it's discouraging questions, but I just have one question for you, Professor Atukorale. You were talking about the dose of JAK inhibitors, which would sort of predispose to certain infections.
So usually the dose, the higher the dose, the greater the chance of infection. And that has been proved in many studies. The doses we use generally tend to be very small because of the cost, and our patients are still paying it out of pocket. But if you use full threshold doses according to the studies, like 10 milligrams and more, you do tend to get a lot of infections. I personally have seen some cases of zoster. I've also seen one patient with TB myositis after baricitinib. So there is that risk. The bottom line is that we need to screen all these patients, and whenever possible to give treatment, give vaccines. But the practical problem is that we can't, because the patient is so ill, and we struggle to just control the arthritis.
Yes, that's correct, yes. Thank you very much.
Even with the other DMARDs, like if you go for higher doses, even with methotrexate at 25 milligrams per week is immunosuppressive. Leflunomide is immunosuppressive. And I think with tofacitinib, our usual dose is like 5 milligram BED, but when you go up to 10 BED, the adverse effects are higher. But I think the studies, as I remember, like a few meta-analyses do show that the efficacy is better.
The efficacy is always better with the higher dose. But I think for our patients, we may have slightly different pharmacogenetics, and I think all the rheumatologists who are here will agree that our patients are doing better with lower drug doses. So once we understand really what makes our patients different from the typical Caucasian cohorts on which these guidelines and trials are based, I think we will be able to manage with less. And certainly the infection risk is higher in terms of tuberculosis in our population, and our access to vaccination is not ideal as well.
And a lot of the studies that compare the tofacitinib and JAK inhibitors versus the biologics have completely disregarded rituximab, which is one of our first line and the least expensive.
Yeah.
It's not there in any of the meta-analysis.
Yes.
So for us, it is a very sort of efficacious and a cost-effective option compared to the TNF inhibitors. So we need to generate our own data in terms of cost effectiveness as well.
Because all our biologics are mainly given by the state. So 4 injections is cheaper than 1 injection every month. But in the West, they are focusing on home-based care, and subcutaneous injections which the patient can give actually is game-changing in terms of cost. The problem with rituximab, as I see, particularly in our setting, is for us to identify patients who have hypogammaglobulinemia. We can't assess that until they come with severe sepsis. So that is a big problem. I think you will all agree about that one, yeah?
Yeah, and particularly those who have congenital gammaglobulinemias, like congenital immunodeficiency syndromes, because we know that congenital, particularly these combined immunodeficiency syndromes, those patients are at a higher risk of developing inflammatory arthritis as well, particularly difficult to treat one. So we recently dealt with such a child who had come with recurrent episodes of HLH and kind of protein-losing nephropathy also. So some sort of an immunological syndrome, but we can't really put a finger on what exactly that was. Responded very well to rituximab, but just after 3 doses, she started developing recurrent infections. And then we sent to MRI for immunology review only to see that she had a common variable immunodeficiency. So started on IVIG and that disappeared. So it's very tricky trying to immunosuppress in patients like that. And when we don't have the baseline screening that is recommended for patients before starting on rituximab, it's very difficult.
We are losing a lot of drugs because we don't do the pre-drug workup effectively, I think, and our patients are suffering. This is the dilemma we have with this low-cost setting that we are working in.
We actually take anti-CD19 levels before giving the next dose. If they're still depleted, we delay and we give later after rechecking.
Another small question. So what is the recommended dose rituximab in our setup, and how do you repeat the injections?
So the 1 gram standard is what is recommended for patients across the guidelines. But I'm wondering whether for our patients, less might be more. I think the bigger way that we need to sort this out is to do trials of our own, and that is the way we need to go, because otherwise we are going to over B-cell deplete our patients, and we can't do CD19s as often as you do, so our patients are the worst for it. Yeah. Yes, there is a trial, yes. So we are doing, I think Chiranthi and the pharmacology department is doing some pharmacogenetics work, so hopefully we will get some ideas.
And for rituximab, there's a trial done by Professor Galapati, and I think Dr. Lalita Jeeratne was also involved, where they tested it. It was a clinical trial testing 500 milligrams versus 1 gram of rituximab, where they found comparative efficacy in rheumatoid arthritis. So we do have evidence that lower doses
we need to match the trial with the radiographic data, the quality outcomes, and the DAS, the CAS, everything for people to accept our decision, really. I agree that might be the way forward, but we can't use lesser doses until we prove it.
And one other thing, like with the dosing of rituximab, is I think the overall inflammatory burden of the patient should be taken into account. I think that's what you were trying to say with the DAS28 and the inflammatory markers and everything. Because particularly with frail patients, I tend to go with 500 milligrams. I'm too scared to use the 1 gram because of very bad experience. Particularly with infections like tuberculosis, no matter like you screen, they are negative for the tuberculosis skin test, but then they come just 6 months after with cavitating lung lesions. So I think it should be an individualized kind of patient-based decisions, but I agree, like the international recommendation, particularly the production recommendation is 1 gram.
We have to have our own data, and I think that's the way forward.
Thank you very much, all the speakers and panelists. And now may I invite Dr. Sujeevani Kurukulasuriya, my co-chair, to give the token of appreciation.
Thank you. Yes, call the names. Okay, call the names, no? Yeah, okay.
Okay, may I invite Professor Ian Cameron to give the certificate from Dr. Sujeevani. Now, may I invite Dr. Chamila Dabare to get the award from Dr. Sujeevani. Professor Inoshi Atukorale to get the token of appreciation. Chathurika Dandeniya to get the token of appreciation. Now, Dr. Sujeevani Kurukulasuriya to award the token of appreciation to Dr. Chiranthi Liyanage. Okay.
Could I also invite Dr. Chiranthi Liyanage to award the certificate and letters of appreciation to our chairpersons?